This video will cover some important concepts regarding ACS management with reference to definitions, investigations, presentations, management, prognosis and complications. Definitions. ACS, acute coronary syndrome, is a spectrum of coronary artery diseases which includes unstable angina, non-ST elevation MI and ST elevation MI. A clinical myocardial infarction is defined as an acute myocardial injury identified by an increase in cardiac biomarkers in the presence of evidence of acute myocardial ischemia. The epidemiology. So ischemic heart disease is the most common cause of death worldwide. Within the UK, it accounts for 80,000 hospital admissions, and the mortality with 30 days for STEMI is 8%. Interestingly, the mortality at 1 year is high for NSTEMIs, which is 15%, compared to a 10% for an ST elevation MI. The classification, so they can be classified into ST elevation MI, so ST elevation on the ECG, or non-ST elevation, which is further subclassified into non-ST elevation MI and unstable angina. In comparison of these two pathologies, NSTEMIs are associated with troponin rise, while unstable angina is associated with no necrosis and therefore no troponin rise. Myocardial infarction can be classified into 5 subgroups based on etiology and circumstance. Type 1, this is due to primary plaque rupture. Type 2 is due to ischemia due to increased oxygen demand or decreased supply, for example hypovolemia or hypoperfusion. Type 3 is sudden unexpected death, often with symptoms suggestive of myocardial ischemia. Type 4 is secondary to percutaneous coronary intervention, and Type 5 is due to post-cardiac surgery. The degree of transmural necrosis cannot be precisely determined clinically, and therefore infarcts are usually classified as STEMI or non-STEMI by the presence or absence of ST elevation or Q waves on the ECG. The size of the infarct can be therefore transmural or non-transmural. Transmural relates to full thickness and therefore leads to the formation of Q waves, and non-transmural is partial thickness, which leads to ST segment and T wave changes. The diagnosis of ACS is based on history, risk factors, ECG changes and further investigations. These will be discussed individually in due course. Risk factors. These can be modifiable or non-modifiable. Non-modifiable is therefore increasing age, sex, family history, presence of diabetes. Modifiable would be smoking history and obesity. Patients with these risk factors are therefore at a higher risk of ACS. ECG changes are common within ST elevation MIs and non-ST elevation MIs. ST elevation MIs are therefore indicate ST segment elevation of greater than 1 mm in 2 consecutive limb leads or 2 mm in 2 consecutive chest leads, or new left bundle branch block. Conversely, an NSTEMI or non-ST elevation MI will lead to ST segment depression and or T-wave inversion. Troponin is an important cardiac biomarker which may suggest myocardial injury. However, it should not be used independently due to the factors which can also increase myocardial levels of troponins. These include a reduction of myocardial perfusion, i.e. due to coronary artery dissection or spasm, myocardial injury from infiltrative diseases, i.e. sarcoid or heart failure. In addition, those conditions which increase myocardial oxygen demand, for example, arrhythmia, sepsis, and those which increase RV dysfunction, so PE and pulmonary artery hypertension. And finally, those which of the CNS pathology, subarachnoid hemorrhage. Troponin is cleared by the kidneys, and therefore kidney impairment in the form of CKD can lead to an increase in troponin level. This slide covers the criteria for the diagnosis of type 1 and type 2 MI. For type 1 MI, we have a raised troponin above the 99th centile of the upper reference limit, plus evidence of myocardial dysfunction in the form of symptoms, ischemia on an ECG, development of pathological Q waves, new regional wall motion abnormalities on echo, and identification of a coronary thrombus by angiography. This graph demonstrates the magnitude and duration of key cardiac biomarkers. The URL is the upper reference limit, and on the y-axis is the multiples of the cutoff of the limit, and on the x-axis is days post-MI. We use troponin, which has the highest magnitude and the greatest duration. Other markers include myoglobin, which has a rapid acute increase and decrease, and CK. The differential diagnosis for chest pain is broad and covers breathing pathologies, cardiac pathologies, gastrointestinal, and finally musculoskeletal, so it's important to keep an open mind. Early management of myocardial infarction is relatively complex and can be split into medical and surgical interventions. Medical interventions can be further split into non-ST elevation MI and ST elevation MI. Classically, patients with a ST elevation MI may require primary angioplasty leading to angiography and primary PCI, in addition to medical management. However, thrombolysis is also an option. For non-ST elevation MI, patients classically undergo medical management, angiography plus or minus PCI. The timing of the PCI is based on multiple factors. Immediate PCI is suggested due to hemodynamic instability, recurrent symptoms despite medical management, mechanical complications, and life-threatening arrhythmias, whilst early management, i.e. less than 24 hours, is due to a Gray score greater than 140 and transient ST elevation. The Gray score is made up of multiple factors as shown: patient, observational, history, examination, investigation, and end organ dysfunction. The outcome of the Gray score is to give you a number, but also a probability of death at 6 months. With regards to the medical management, this highlights some key medication overview. Early management includes oxygen if the saturation is less than 90%, nitrates to relieve ischemic pain, in addition to opioids. Antiplatelet therapy includes COX-1 inhibitors, including aspirin, and P2Y12 inhibitors, including clopidogrel. Other agents include tirofiban and noxaparin, which are GP2B3A receptor inhibitors and anticoagulants, respectively. Longer-term management includes antiplatelets, so dual antiplatelet therapy is usually required for 12 months, and after 12 months, only single antiplatelet therapy is usually required, in addition to beta blockers, ACE inhibitors, and statins. The cardiac complications following MI are broad. We'll first focus on the cardiac complications. These include arrhythmias, myocardial dysfunction leading to cardiogenic shock, in addition to septal rupture, aneurysm, and reinfarction. Patients can develop acute valvular abnormalities, including mitral regurgitation, and pericarditis in the form of post-myocardial infarction, i.e. Dressler syndrome. Patients are at risk of embolic phenomenon, but also as the degree of cardiac dysfunction increases, i.e. cardiogenic shock, patients may be unable to maintain an airway, develop pulmonary edema, and acute liver and kidney dysfunction. The ongoing management post-myocardial infarction can be split up into conservative and medical measures. Conservative measures include improved diet, exercise, weight, and psychological support, in addition to a reduction or absence of smoking and alcohol. Medical management includes ongoing medical management, in addition to the use of an influenza vaccine. If you like our contents, please like and subscribe. Thank you.